Welcome, future doctors. If you're an MBBS student gearing up for your nephrology blocks or those looming university exams, you're exactly where you need to be right now. As a medical educator, I know how tricky this topic can get. So today, this explainer is strictly focused on high-yield, exam-critical concepts. We're going to conquer the pathophysiology, clinical presentations, and those absolutely crucial diagnostic distinctions of renal failure. Okay, let's dive into this.
Here's our roadmap for today. We'll start by defining renal failure, move on to acute versus chronic distinctions, and then classify acute kidney injury. After that, we'll look at the pathophysiology of renal injury, track chronic kidney disease progression, and finally, wrap up with clinical presentation and prognosis.
All right, Section 1, Defining Renal Failure. Let's establish our clinical baselines.
Let's set those clinical baselines by looking at urine output. First up, oliguria. We're talking about a urine volume of less than 400 milliliters per day. This is a massive red flag, right? It's something that very often precedes acute kidney injury. Why? Well, because conditions like intravascular volume depression trigger the renin-angiotensin-aldosterone system along with ADH release, which promotes intense sodium and water retention. Then we have anuria, which is less than 100 milliliters per day. Now, when your patient is anuric, you need to immediately suspect a severe anatomical blockage. Think complete prostatic enlargement, or maybe a catastrophic lack of perfusion, like an aortic dissection that's involving the renal arteries.
Moving to Section 2, Acute versus Chronic Distinctions. It's time to differentiate AKI and CKD.
Let's move to and see how this builds. Notice the stark contrast between these two. Acute kidney injury hits suddenly. We're talking about an acute insult, like ischemia or toxins. But the silver lining here, if you catch it early, it's potentially reversible. Plus, if you grab an ultrasound, you'll typically see normal-sized kidneys. Now, chronic kidney disease is a completely different beast. CKD develops insidiously over months, sometimes years, representing an irreversible deterioration of nephrons. And crucially, on that ultrasound, CKD typically presents as bilateral small kidneys, often with evidence of cortical scarring. I can't stress this enough. This imaging distinction is classic exam material.
Let's hit Section 3, Classifying Acute Kidney Injury. We're taking the anatomical approach here.
You've got to categorize AKI into three distinct pillars: pre-renal, intrinsic, and post-renal. Pre-renal AKI is all about reduced kidney perfusion. Think of a patient in severe hypovolemia or cardiogenic shock. The kidneys themselves are structurally fine, but they literally aren't getting the blood flow they need. Next, renal or intrinsic AKI means there is direct injury to the kidney tissue itself. The classic, most common cause here is acute tubular necrosis, but it definitely includes inflammatory conditions like glomerulonephritis too. Finally, postrenal AKI. This is essentially a plumbing issue, an obstruction of urine flow. But here's the kicker. The obstruction absolutely must be bilateral to cause systemic renal failure. We're talking bilateral uretic stones or maybe a severely enlarged prostate blocking the bladder outlet.
On to Section 4, Pathophysiology of renal injury. Let's look at the actual mechanisms of damage.
Now, what's really interesting about this slide is how perfectly the physiological failure maps directly to your exam-critical lab findings. Look closely at the difference between pre-renal AKI and intrinsic AKI, caused by acute tubular necrosis. In pre-renal AKI, the nephrons are desperately trying to hold on to volume. The RAS is hyperactive, aggressively pulling sodium back into the blood. Because of that, urine sodium is remarkably low, under 40 millimoles per liter, and the fractional excretion of sodium, or FeNA, is strictly less than 1%. You're also going to see a high specific gravity thanks to ADH. But in ATN, the tubules are necrotic. They physically cannot reabsorb sodium anymore, so that urine sodium spills right out, climbing way above 40. FeNA jumps to 1% or higher, and under microscopy, you'll spot those pathognomonic muddy brown granular casts made entirely of dead tubular cells.
So, what about post-renal pathophysiology? Imagine the sheer mechanical back pressure. A bilateral obstruction elevates the intraluminal pressure inside the ureters. This pressure physically transmits backward, right up into the nephrons, directly counteracting and dropping the glomerular filtration rate. But guys, it gets worse. If that obstruction isn't relieved quickly, the kidney initiates a totally maladaptive response. It actively drops its own renal perfusion using potent vasoconstrictors like thromboxane A2 and angiotensin II. So what started as a simple mechanical blockage rapidly transitions into chronic tissue injury.
Section 5, Chronic Kidney Disease Progression. It's time to track the decline.
We stage CKD based on the glomerular filtration rate, or GFR, and knowing exactly when specific clinical complications pop up is vital for your exams. Stage 3A, which is a GFR of 45 to 59, is usually completely asymptomatic. You won't see much. But by stage 3B, a GFR of 30 to 44, renal anemia starts to emerge. Why? Because those failing kidneys simply stop producing enough erythropoietin. Once your patient hits stage 4, a GFR of 15 to 29, they have severe CKD. This is the danger zone where the kidney completely loses its ability to manage acid-base and fluid balance, meaning severe electrolyte problems like hyperkalemia become highly likely. And finally, stage 5. That's a GFR below 15. This is end-stage renal disease. At this stage, the patient absolutely requires renal replacement therapy like dialysis, and a whole cascade of significant uremic symptoms takes hold.
Section 6. Clinical Presentation and Prognosis. Let's talk about spotting uremia.
When a patient reaches advanced CKD, their body literally tells the story. You have to pay close attention to the extremities, and this brilliantly illustrates what you're looking for. You'll often spot the classic brown line pigmentation right across the nail beds, alongside distinct splinter hemorrhages. These are hallmark, extremely high-yield signs of advanced, long-standing uremia. You do not want to miss these on a clinical exam.
But the systemic signs go much, much further. Patients with advanced end-stage renal disease very often display an increased respiratory rate and depth. We call this Kussmaul breathing. It's a direct respiratory compensation for the profound anion gap metabolic acidosis caused by retained organic acids in the blood. You'll also see severe excoriation on the skin from uremic pruritus. They just can't stop scratching. And if you put your stethoscope to the heart, fluid overload might present as extra heart sounds, or you might hear a harsh pericardial friction rub. That rub indicates uremic pericarditis. These patients are systemically toxic.
So the crucial point is knowing exactly how to apply all this to a real patient. Consider this clinical vignette. A 68-year-old man in the ICU with severe COVID-19 develops anuria and suddenly requires dialysis. What is the most likely cause? Think about the pathophysiology we just went over. The answer is A, acute tubular necrosis. Now, while he likely had pre-renal failure earlier on due to his critical illness, the sheer severity of developing complete anuria implies the renal tissue itself has become ischemic and necrotic. Obstructive nephropathy? Highly unlikely in this specific ICU context. And metformin accumulation? That causes lactic acidosis, not acute kidney injury itself. Mastering these cellular mechanisms is how you become an exceptional clinician. But it leaves us with a lingering question to ponder. If the structural damage in ATN is so devastating and hard to reverse, how close are we to finding reliable, early biomarkers that can detect this intrinsic injury before anuria even sets in? Keep questioning what's beneath the surface.